Let's be honest, for anyone in training, the pediatric respiratory exam can feel like this massive, intimidating checklist. But what if you could stop seeing it as just a list to memorize and start seeing it as a logical system? A system that builds real clinical confidence. Well, let's break that down.
Right, that's the million-dollar question. How do we go from just ticking off boxes to actually understanding what we're seeing and hearing and feeling? Today, we're going to walk through a systematic approach that's going to totally transform how you do this exam.
You know, every great exam starts with a solid foundation. Before you even touch the patient, two things absolutely have to happen. First, a professional setup. Second, a really careful first look from the end of the bed. These first steps, they set the stage for everything else.
Okay, first things first, the wiper protocol. This should be like breathing, just second nature. It's wash your hands, introduce yourself to the child and the parents, ask for permission, make sure you have proper exposure of the chest while keeping their dignity, and then reposition everyone so you're both comfortable. It's simple, it's respectful, and it's non-negotiable.
Now for that first look, the ABCDE framework is your best friend here. A is for their overall appearance and any audible sounds you hear right away. B is for their posture and body build. C is for colors, are they pale, are they bluish? D is for any signs of distress, and we're going to dig into that in a second. And E is for equipment. Is there an oxygen tank, a nebulizer? This quick scan gives you a vital snapshot of what's going on. So let's zoom in on D for distress, because these are the big red flags. You've got to look for the nostrils flaring with every breath. Watch for recession. That's when the skin gets sucked in between the ribs or above the collarbones. And notice if they're using those extra muscles in their neck to breathe. All of these are screaming that this child is working way too hard just to get air in. All right, so with that general impression locked in, we move to the preliminary scan. This is where we zoom in on the hands, the face, and the neck. Why? Because these areas can offer some powerful clues about what's really happening inside the respiratory system. The hands are like a little bulletin board for the rest of the body. You'll feel their temperature, you'll look for signs like clubbing, which can point to chronic low oxygen, as well as any cyanosis or paleness. A fine tremor could be a clue about their medication. You'll also check for specific nail changes like koilonychia or leukonychia. And hey, don't forget to look for that BCG scar, could be relevant. And let's quickly define one of those fancy terms, koilonychias. It's really simple. It just means spoon nails. So instead of that normal curve, the nail goes flat or even dips in like a spoon. It's an important little detail to catch. Okay, so moving up from the hands, we do a quick scan of the face and neck. On the face, again, we're looking for that paleness or bluish tint, but also any jaundice or redness in the eyes. Then on the neck, we're checking for any tracheal tug, that accessory muscle use we talked about, and any obvious swelling or pulses. And now we've arrived. The main event, the core examination of the chest itself. This is where we take everything we've observed so far, and we combine it with a real hands-on assessment. This exam follows a very strict logical flow. There are 4 stages, and they have to be done in this order. Inspection, which is looking. Palpation, which is feeling. Percussion, which is tapping. And finally, auscultation, which is listening. If you stick to this structure, you won't miss a thing. For stage 1, inspection, just remember the mnemonic read SMS. R is for the rate and pattern of their breathing. S is for the shape of the chest and its symmetry. M is for movements, especially how their chest expands. And that last S is for any scars or other things you see on the skin. You're basically building a detailed visual map. Next up is palpation, using the mnemonic PTCT. Here, you're checking for pain and the position of the trachea and the heartbeat's apex, which can tell you if things have shifted inside. You'll feel for any tenderness, check their chest expansion for symmetry, and finally, you'll evaluate tactile vocal fremitus, feeling for vibrations as they speak.
Stage 3 is percussion. This is where you'll tap systematically all over the chest. A normal, healthy, air-filled lung? It sounds resonant, kind of hollow. But if you hear something dull or stony dull, that's a huge clue that there might be fluid or something more solid under your finger.
This is such a great question, and it's a critical one. I mean, this whole systematic approach is wonderful, but a squirming toddler who just wants to get down and play isn't always going to cooperate, right? So, do we stick to the plan? And here is the pro tip, the crucial adaptation. For infants and toddlers, you flip the script. You start with listening, with auscultation, while they're calm and quiet. Get the hardest part done first. Then you move to feeling, and you only attempt percussion, because it might not even be useful. The takeaway? You always adapt your technique to your patient. So when you're auscultating, what are you actually listening for? You're basically asking yourself a series of questions.
Is the air entry good on both sides? Is it equal? What type of breathing am I hearing? Are there any extra, added sounds like crackles or wheezes? You'll also check their vocal resonance and, importantly, listen to those heart sounds.
We are not done yet. A truly thorough exam isn't just about what you can see from the front. To really complete the picture, we need to assess the patient's back and take a look at their lower limbs.
Now for the back, it's pretty straightforward. You're basically going to repeat the same 4 stages you did on the front. Inspect, palpate, percuss, and auscultate over all the lung fields. Then, it's a quick check of the lower limbs for any swelling or edema, and one more look for nail clubbing. That completes the physical part.
So, you've gathered all this incredible information. You've looked, you've felt, you've tapped, and you've listened. But the final, and maybe most important skill, is synthesis. It's about putting all those pieces together into a coherent story.
A professional summary follows a really clear 4-step structure. First, you always state the presence or absence of the big stuff: distress, cyanosis, clubbing, and the respiratory rate. Second, mention any other important abnormalities you found. Third, you detail your specific findings from feeling, tapping, and listening. And finally, you state your conclusion. These findings are consistent with, and then you give your potential diagnosis.
And to be 100% complete, the exam doesn't just stop at the chest. You're going to finish by checking all the other vital signs, taking measurements like height and weight, examining their lymph nodes and ENT system, checking their O2 sats, and thinking about what other tests you might need.
So, there you have it. We've taken that daunting checklist and turned it into a dynamic, logical system. You now have the framework to go from just following steps to truly understanding the story a patient's breathing is telling you. The only question left is, what are you going to discover the next time you listen?